Thank you very much. This is coming home day for me. I used to work at Maimonides, like you mentioned, and I drove past on my way here just to say hello. This is a different type of topic than what you're used to. This is not, the latest research on how to treat asthma or COPD, but it's hopefully something that is of daily interest to you, in that it's the how do you use healthcare efficiently. And you'll notice much of the citations, I give this talk every so often, but the citations, most of them are from this year, if not this month. So some of these issues are still ongoing. I will try to fly through this as fast as I can so that we have time at the end for questions, but let's see how it goes. So the usual view of this is that this type of talk was sort of anathema in medical circles, probably as recently as 10 years ago. The doctors are the good guys, we're taking care of patients, and the payers and the people who hold the money are the bean counters, and if they would just leave us alone and let doctors be doctors and they can work out the money stuff, everything would be great. And if there's a money problem in medicine, it's because the insurance companies are taking too much profit and their executives are making too much money. And it doesn't mean that those things aren't necessarily true, but there's a much bigger problem at it than that. So what I am here to propose is a second paradigm, which is to acknowledge upfront that the vast majority of doctors are trying to do the right thing. Medicine is a noble profession. We're here, we are different, and I'll get back to that. And because we're different, we should be held to a higher standard. But we can't ignore the reality. And those of you, I think this is the student side? Yes. You guys are growing up in a world where it won't be unusual if a case manager comes up to you and says, do you think the patient could be discharged today? Probably some of the young docs, it's not so bad. There is a cut, to me, old is always 10 years older than what I am, so old keeps getting older. But, there is a tradition in medicine in the old days where that just wasn't discussed. I decide what I do with my patients. No one else is allowed into that. And the world of the payer and the money and, the cost and the reality of this has made these discussions not only necessary but critical. So, for example, if we don't control costs, in this country, it's not just the medical world, but, the budget. A lot of the budget problem is really boils down to Medicare and other healthcare costs. So the issue is, in the care of patients, how do you say no? Who says no? No, you don't need an MRI for that headache. No, before you get the back fusion surgery, let's try physical therapy. Often it's the clinicians, but often in our system right now, that end is the payer. The people with the money are the ones saying, not yet. And in fact, this whole shift to ACOs, which is just, I think, another way of saying capitation, is to shift that pile of money to groups of docs. So they'll be the ones asking those questions instead of the big bad payers. But it's the same idea. The same idea is who's going to make sure care is being done rationally. And what I'm going to talk about today is to make the case that just saying let docs be docs, without guidelines, without any sort of input from other people, which is the way we've done it until recently, is not going to work. That's not going to control costs. For lots of reasons, not just the doctors. So it's the old adage, what's the most expensive medical technology in the world? It's a doctor's pen. Now it's probably a doctor's computer finger. But the idea is almost all of the costs in medicine come from the things we order and or suggest and or provide. I'm going to be flying through a lot of evidence, and I'd like to break the evidence myth a little bit by saying not everything can be studied. The British did this in the BMJ, now it's almost 10 years ago, saying, well, we did a systematic review looking for randomized controlled trials to see if parachutes work if you jump out of a plane. And they said we could find no randomized placebo-controlled trials, so therefore we can't say that parachutes work. Now, obviously, this is ridiculous, right? But this is to make the point that not everything can be studied. But that's a long way from saying nothing can be studied. sometimes it's, well, you can't study medicine. It's judgment calls. It's, it's the art. And yes, there is that aspect, but it doesn't mean that there's no science to it. So I just wanted to break some of the myth. Not all evidence is possible. So we have some of the best in this country. If you want a heart-lung transplant, this is probably the place to be. If you want a stent in your coronary arteries, this is probably the place to be. But despite what some politicians say, it's not the best, period, and no change necessary. That there's a cost problem, and I've already talked about who says no. Interestingly, we don't always get value for our money, and that's sort of a separate talk, but just the underlying thing is, it's not just about, well, if we spend more money, we'll get better health care. So this is the first slide, which is showing that we are different. The United States is somehow different from almost every other country in terms of how we spend money on health care. So it's not the lack of trying to get fantastic health care. We spend a fortune on health care, and we're different from pretty much every other country, and it's pretty much a recent, this generation, a generation before phenomenon, since 1980. And you can see that it's these other countries that people aren't exactly walking like flies in the street, right? These are other developed OECD countries, and we just spend a order of magnitude different. And interestingly, it's not because we get more health care. If you look at things like the number of docs per population, or the number of doctor's visits per population, or the hospital discharges, we don't do more of that stuff than other countries. In fact, in some ways, we do less of it. And length of stay, it's funny, when I look at the length of stay literature, there are some countries that you can never, in Japan, for some reason, people stay in the hospital forever. So you can never get well, gee, how short a length of stay is safe and possible. You're not going to get that from the Japanese literature. On the other hand, the Japanese doctors, I understand, are paid by the number of prescriptions they write. So the Japanese, not surprisingly, have the most prescriptions per capita. And this is the phrase, to a man with a hammer, the whole world looks like a nail. So, if you have it, if you build a cath lab, it's going to be used. If you are an orthopedic surgeon, you're going to do orthopedic surgery. So that's the sort of issue that comes up with fee-for-service. So we don't do more health care. We spend a lot of health care. And then this is the final angle of it. We don't get a lot for our money. This is sort of a difficult slide to look at. But it basically makes the point that compared to the other developed Western economies, we don't have better health outcomes. Whether you look at things like infant mortality or life expectancy after the age of 65, that, we are okay in some measures, but certainly not compared to that curve of our spending. We're not, so the phrase is we're not getting value for our money. And this is not controversial. All sides of the aisle would say that this is true. What to do about it is a different matter. And then finally, this one, when I update this talk, I look for new things, and sadly, it's easy to find new things. So very recently, the Congressional Budget Office, as well as CMS, have made these estimates that if we don't change what we're doing, if we just keep doing what we're doing, basically, this is completely unsustainable, right? You can't have 40% of the federal government spending go to health care. It has to pay for things like an Air Force, an Army, the FBI, the CIA, Social Security, lots of education, lots of other things, research, lots of other things come up. So this is just a completely unsustainable number. Which is why even people in Washington are getting a little excited about this. So every so often I'm going to sprinkle in some quotes. Because Brooklyn is the heart of American comedy. Almost every good American comic has come from Brooklyn, or makes a joke about Brooklyn. So the phrase, the easy answer is get rid of the waste. So there's two problems with this. One is, what do you mean by waste? Do you mean therapies that have no benefit? Zero. Okay, that's not where the money is. Do you mean fraud and cheating and stealing, which also seems to be, whenever you read the paper, there always seems to be some Brooklyn or Queens group that, I don't know, it's higher than per capita, but nobody here, I'm sure. But that's not where the money is either. That's too easy. Is it? Well, gee, it works, but a little bit, and it's very expensive. That might, and we're going to come back to that, but that might be the area. But that's tough. That's difficult. You know, that's not death panels, but it's rationing. It's, you know, in Britain, above a certain age, you don't get dialysis. Can you imagine doing that in this country? It just wouldn't get past the front door where, you know, you're 80, so therefore you can't get dialysis. That would just never happen. But, you know, from a cost perspective, it makes sense. But so there are tough decisions, but we've never made those decisions in an official way. And whenever we come close to it, it gets very controversial. Does everybody remember the USPF, TSPF report on mammograms? And how a third rail that was? And basically, they had the science right. They had the politics wrong. And, you know, they were saying things like, if every other year is almost as good, starting at 50 is almost as good, and there's all these downsides to doing it early. People didn't want to hear that. All they said, my mother had 44, had a mammogram, and saved her life. And that's the end of the discussion. And so we're not very good at the weighing the pros and cons. We just see the pros. So, in the end, in a fee-for-service system, it might be doomed. That's why we're trying to move from a fee-for-service system. But in general, the answer to our healthcare economic problem, which is really the root of our national economic problem, is doctors practicing more cost-effective, almost like thoughtful, mindful medicine. So in other words, this is the most important thing in the world that we're talking about today, which is what every speaker says, right? So, easier said than done, right? So this is the famous chart of, anybody seen something like this before? Yeah, the election, right? Actually, it's not quite, but, because that's the New York thing. This is the thing that sort of started it all. Okay, you don't want to talk about cost. A more gentle topic is variation. How come they spend so much more money in New York and Miami than they do in San Francisco and Portland? And after you control for the fact, all the clinical factors you want to control for, it's still there. And it's large. It's 50% more per capita. And so that type of unexplained variation got payers, including Medicare, very interested in saying, well, what's this about? Why should this be? And just another way of looking at variation, this is a brand new study from the New England Journal, looking at a 5% Medicare sample. So this is a huge sample. This is not going to be skewed by chance variation. And they found that discretionary things, like do I admit the patient, do I not admit the patient? How many office visits? When is that follow-up? You all do follow-ups like 2 weeks, 4 weeks, 6 weeks in your clinic? There's no guidelines on when to do that, right? Should I see him in 4 weeks or 6 weeks? Doctors do it differently. Doctors, do the residents of the room agree that ER attendings tend to have a different threshold for admitting a patient? We agree that inpatient attendings tend to have different lengths of stay? Yes. So there's variation in Lutheran. You can imagine there's variation in the country. So this just shows you, from the 75th to the 25th percentile, there's 20-some-odd% difference. And from the 90th to the 10th, which means it's still 1 in 10 on either end, there's a huge difference in these decisions that we make across the country. I love to show this slide in New York audiences because these are goal lengths of stay for certain disorders and the national attainment. And usually New York audiences find these very, very surprising, which sort of brings up the issue of local culture. In New York, we tend to admit. In San Francisco, less so. In New York, we do lots of ICU and consult specialties to the end of life. In San Francisco and Portland and other places, a little bit less so. What about length of stay? So, let's see, what would be a good example? Have any of you ever treated a patient with ischemic stroke, confirmed ischemic stroke, who was discharged in 2 days? Nationally, it happens about a quarter of the time. I agree, when you look at the charts, it's not here, not local. How many of you have ever heard of an ambulatory complete mastectomy? In New York, it's sort of not done. They didn't want to hire me to be on the writing guidelines. They're like, you're coming from the belly of the beast. You're not going to help us. And, New York is part of the problem. So this is the culture. So first of all, this is just a reality that it can be done. This is not, evil, unsafe. It can be done. Now, it's not just a matter of saying discharge. You have to have systems in place. You have to have home care. Lots of things have to happen. So, it's not for nothing that New Yorkers have longer lengths of stay, because we probably have underdeveloped outpatient capabilities compared to other areas. But this is sort of one of these, gee, it can be done slides. So this is like, well, it's easy to give advice, it's harder to take advice. So just to make it clear, multiple studies have made it clear that spending more money in and of itself doesn't lead to better health outcomes. At best, it's neutral. That's maybe waste. At worst, it can actually do harm. Have any of you ever seen a patient who the right answer is, for goodness sake, just stop it and send them home because we start chasing our tail? The little old lady with mental status changes, and at like day 2.5, you've lost the race. Because one thing's going to lead to another. The following leads to a UTI, blah, 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 and you're off to the races. So you can see how more can make it worse. Why do we do this? I think it would be dishonest to not put fee-for-service at number one. Doesn't mean doctors are money hungry and evil. It's human nature. If you make your living doing colonoscopies at $1,000 a pop, and somebody comes to you with a borderline indication for a colonoscopy, more often than not, you're going to do a colonoscopy, right? If you go to a mechanic, how often do they say, nothing's wrong, thank you for asking? Have you ever had a consult where they said, you're doing fine, thank you for asking. I have no suggestions. It's rare. People tend to want to do what they do. And if you also add, this is how they make their living, it becomes very difficult to control costs, because you're basically telling people to, be superhuman in terms of sacrificing, and that's difficult. And in general, we have a problem where we pay things like cabbage and stents and procedures much more than talking with the patient for 20 minutes to make sure their medicines are reconciled. And that's a problem. And patients want, have you ever had the conversation where it takes 20 minutes to tell somebody they don't need an antibiotic? And it takes a minute to write the prescription for the antibiotic? You have a busy day. You have to pick your battles. That's also true for head CTs, MRIs, colonoscopies. I mean, it's a running joke with my mother-in-law. She asks my opinion and does the opposite. It's sort of, and she's healthy, so maybe she's doing the right thing. Defensive medicine is a part of this. I don't think it's most lawsuits, but there are lawsuits where people do everything by the letter. And because they had that conversation and said you don't need a PSA screening, and the person 10 years later gets prostate cancer, they can be sued for it. Maybe not successfully, but that's not even the point. So the point is this does play a role. People differ on how big a role. And there's the technology creep. Something is good for a certain population, PSA screening, and it gets exploded to pretty much anybody with a P that might have an SA. And it's just, the pre-test probability, head CTs for headache. Is there a group that needs it? Yes. Is it everybody? No. Because your chance of finding something is so low, whatever you see is going to be a false positive, not a true positive. looks pretty bleak. And Woody Allen is the chief amongst Brooklyn comics. So, you know, the days when doctors can pretty much say, this whole nonsense has nothing to do with me. I'm more interested in taking care of patients. You can't do that anymore because our decisions carry too much weight and lead to too many things that we really have to say that we are it. We have to provide evidence-based medicine when we can and make those decisions almost intentionally, not reflexively. The problem is waste, it depends. So this is a new slide, so it might be too much, but Don Berwick, who tried to do something and went out of Washington for it, that was my only political comment, probably the smartest person to ever be in Washington and had a very short tenure because it's not an easy place to say things that need to be said. You remember his confirmation hearings? They tried to skewer him because he once said the British system wasn't all bad or something like that. I mean, that's the environment. So anyway, he's a very thoughtful leader in this area. And he came up with 6 general areas of waste. So one is we just don't do the right things. We don't do the infection control right. We don't do the procedure right. We just don't do things. We don't practice evidence-based medicine. That leads to a lot of money. The other one is the coordination. Anybody ever admit a patient who could have avoided an admission if they saw a doctor or had something done? One phone call, one visit, one this, one that? Absolutely. So there's the coordination factor. There's overtreatment. So this is not just waste, it's sort of the harm we do from too much. What's the downside of getting a head CT for every headache is that you'll find a ditzel. In Brooklyn you can say that. You can find a ditzel, and then you end up chasing that, and you do a test for that, you do a PET scan, and just one thing leads to another. So that, and then just overtreatment. If you do a hysterectomy when a hysterectomy wasn't necessary and that person has complications from it, that would fall into this category. So that's a lot of money. There's the administrative stuff, the forms. The payers have, everybody has a different form, everybody has a different formulary for their medicines. There's all types of ways that this wastes money. Pricing failures is a little bit trickier. For some reason, not some reason, can anybody think of the reason? Medicare is not allowed to use its clout and buying power to get the lowest price for azithromycin in its Part D benefit. Anybody want to hazard, and I'm not actually left of center politically, but it sounds like I am. Anybody want to hazard a guess as to why Medicare was expressly forbidden, unlike every other health plan, from sort of negotiating down the price?
Great monopolies.
Well, it might be a monopoly, but who would be harmed?
Pharmaceutical.
Yeah, the pharmaceutical industry would not be happy if Medicare all of a sudden got to do these sort of things. So they're suggesting let the beast go. Let negotiate. If you want to shop around, if you want to negotiate down a CT price, let Medicare negotiate down a CT price. And then out at fraud and abuse is part of it, but not a very large part. The point of this whole thing was to say that whether you take the high end of their range or the low end of their range, somewhere between a third, a quarter, a fifth of healthcare dollars are probably going to things that don't benefit patients and may harm them. And that is much more than we'd have to save to get out of the problem. When we're talking about bending the cost curve, we're talking about small percentages of increase. Just slow the increase to inflation would be all of those required. So this type of savings would be way, way more than we would need. So let's get to the doctors don't always do the right thing, so maybe a guideline or some sort of rules are sometimes necessary. So an example would be arthroscopic debridement of the knee for osteoarthritis. Most of you probably are too young to have experienced this, but this was all the rage in the 90s and 2000s. And it was before there was any evidence, at least randomized evidence. There was observational trials that it was a good thing, but the problem is those are always hopelessly biased. And by the time the randomized trials came out, which showed with pretty good precision that it's not a benefit, millions of people had had it already. This is an example of the problem. That the cat gets out of the bag, the latest, greatest technology is out there, everybody wants it, everybody does it, and who's going to say, what's the evidence? Does it work? Now you would think, the orthopedists should know, but again, they have their own problem in terms of bias. And, so the big bad payer might have been the one to say no. In this case, they didn't say no very much. So the adage is, the plural of anecdote is not data. That's going to be on my tombstone. Ronald Reagan had the two most demeaning jobs in the country, President of the United States and radio broadcaster. That just has nothing to do with nothing, but it's very funny. So by the way, we do ration. There's lots of uninsured. Do you have any uninsured patients here? Underinsured patients, patients who, I'm talking about all the people who are getting too much medicine. There's people getting too little medicine. That in a just society, they would get more. And, not only from a humanitarian standpoint, but from a dollars and cents standpoint, boy, to give this person their antipsychotic meds for free would save us so much money down the road. To give them their diabetes medicines would save us money down the road. So in general, this is just one of those things that they study, and you're like, well, gee, did that need to be studied? But everything needs to be studied eventually. Being uninsured is bad for you. Bad things happen. You forego care, you forego medicine, and in general, bad things happen. So we do ration. We ration by ability to pay, by access. An example would be, can you imagine, in this country, we don't use enough statins. Have you ever admitted a patient who wasn't on a statin? It's very rare, but there are patients out there who need a statin who aren't on a statin. And in this day and age, they're all generic. I mean, there's really no other explanation for it than just, and it's not just doctors. There's a lot of things going on here. So this would be an area where we underuse healthcare. Things like colonoscopy are weird because we do both overuse and underuse. There's people who need to be screened who haven't been screened. And it's interesting, things like blood tests, it's not hard to get people to do screening. Things like colonoscopy, it's a little bit more difficult to get people to do the screening. But there's definitely, based on your colonoscopy results, there would be a scheduled follow-up of when your next test should be, right? Depending on what they find. So they did a test looking at 3,900 patients all over the country, and they found that having bad polyps or not such bad polyps or no polyps, your follow-up to your repeat exam was essentially the same. So basically, your indication for a follow-up is that you still had a colon, not that there was a clinical decision. It was reflex. This was the recall card went out at 3 years. You have a system in your office that sends out the recall card. It's not based upon need. This type of thing drives payers crazy because they depend upon the doctors to make the decisions when somebody, they can't get into that type of detail most often. But then there's evidence like this which sort of undercuts our faith that they're making decisions correctly. I took a course in speed reading and was able to read War and Peace in 20 minutes. It's about Russia. So another one is ovarian cancer. Nobody suggests, even the American Cancer Society, which has a screening test for everything, doesn't suggest screening for ovarian cancer. Unfortunately, it's a bad cancer. We need to get something better. But unfortunately, the current, despite what you hear on the radio, despite what the testimonials say, the science of it is there's so many false positives, and the test is so insensitive that it's not going to work. So that's the answer, right? Sounds pretty simple. So they surveyed a group of primary care doctors and said, what do you do for ovarian cancer? 30%, actually 1/3, said that one of those tests, transvaginal ultrasound or CA-125 serum, was an effective screening test. That's just wrong. That's the wrong answer. That's a knowledge gap. That's a problem. And then, would you actually screen? A lot of them said they would screen people. And this is just wrong. It's not somebody with symptoms. I'm talking about screening. And interestingly, in this study, what predicted who would screen? It was patient request, not surprisingly. Again, it's a lot harder to have that conversation about why you don't need screening than to screen, and the concern about liability. Solo practice, so maybe they're less in touch with the evidence or something. That's the theory behind that. Physician or physician's family experience with cancer. So this, I guess, points out that doctors are human. And, it's not just ovarian cancer, but if they have a family member who had cancer, I guess they're very sensitized to it. Theoretically, these things shouldn't influence screening. I live on a one-way street that's also a dead end. I'm not sure how I got there. So it's these gray areas that make the difference, I think, in spending. It's not you have a hip fracture, you need surgery. It's not you have a cold, you don't need anything. It's these gray areas. So, who needs a referral to a gastroenterologist for GERD? Who needs a cardiologist for stable angina? Who needs an admission for pneumonia? These types of gray areas are the differences between places. So I'm now going to do some examples of unexplained variation, and some of this might shock you, is the concern about how, the big thing now is shared decision making. Doctors and patients should have a conversation and share, that's the PSA recommendation now, is discuss the pros and cons of being screened and make a decision, which is fine. The problem is, are doctors good at that? And there's some examples of how informed consent doesn't seem that informed. So this is one area that I think is very interesting. So it's pretty much stipulated that if you are ASA class 1 or 2, going for a colonoscopy, you can have your IV sedation, and by heaven, have IV sedation, but you don't need an anesthesiologist. And that used to be the norm. This wasn't controversial. And then, interestingly, Medicare utilization of endoscopy didn't change 2003 to 2009. Commercial utilization increased by 50%, which doesn't make a lot of sense because the commercial population theoretically is younger. But the proportion using anesthesia exploded. All of a sudden, it became, the new thing is to have an anesthesiologist there. Safer or whatever, it makes sense, right? Well, it's expensive. And it doesn't even make sense why it's a higher rate in the commercial group, which is the younger, healthier group than the Medicare group. And getting to the belly of the beast, in the Northeast, it's exploded such that it's the new norm. The new norm in the Northeast is when you get a colonoscopy, you have an anesthesiologist there. Whereas in the West Coast of this country, it's much, much less common. The people on the West Coast getting mistreated, or the people on the East Coast getting overtreated? Either way, this as just an example, a recent example, it can add up. What's the adage in Washington? A billion here, a billion there. Pretty soon you're talking about real money. So then the informed consent issue. So this study actually depressed me. So this was a survey of about 1,200 patients with stage 4 colon cancer or lung cancer. The science is very clear that chemo will not cure them. It's controversial about palliation and is it worth it, is it long enough? That's different conversation. But it will not cure them. That's just the math. So theoretically, anybody willing to put that in their veins should be very clear that I'm getting this for possible palliation, extension of life. Fine. Unfortunately, of those getting chemo, a staggeringly large percentage thought it was going to cure them. Now, as a house officer, this was one of my pet peeves, because some of it was some attendings didn't want to discuss the downside. It became, you don't want to ruin their hope, and it is complicated. But just from an informed consent side of things, how can you say I'm going to take chemo with all the downsides of chemo and just be misinformed about what it can do? And so this gets into the shared decision making. If we're going to say that things like PSA, osteoporosis screening, lots of procedures are a shared decision, the patients have to be informed. And this was a large sample, so yes, there's some that don't want to know. You know, we had patients like that. If you treat a large Asian community, that's also, I found, was a group that was hard in terms of end-of-life things, who do you talk to, but just this was a national sample. So, you know, that wouldn't explain this. And then, what predicted, this, if this wasn't bad enough, what predicted the patient saying the wrong answer? So, definitely ethnicity. I don't know, maybe it has to do with where they were seen, or there are cultural differences in terms of what you want to know, but these are huge differences. But look at this one. If the physician was a good communicator, the patient said, oh, that doc, you know, he's a booby, he's great to talk with. They were more likely to have the wrong answer. So the writers of the article theorized that, yeah, if you give them the answer they want, yeah, this chemo might work, might cure you, they like you better. And that's probably, there's a kernel of truth to that. The problem is it can lead to misinformation. And then you can't talk about costs in American medicine and usage of resources without talking about interventional cardiology. Has anybody in this audience ever seen somebody go for a cath and there is a lesion and it's not stented or surgery or operated on? We call this the oculostenotic reflex. You know, basically a decision to cath is a decision to open what you're going to see. So that decision way upstream of stress test, anything but normal leads to cath, anything but normal leads to stent, is very common. Costs a fortune. And there's very little, any evidence that it does any good. So meaning people should have stents if they fail medical therapy. They should definitely get stents in the throes of acute coronary syndrome. But you know, the vast majority of it, this chronic stable angina, they have a stenosis. And they've done surveys of docs where they test them on the evidence, they know the evidence, then they give them scenarios, I'm going to keep hitting that thing. And then they give them scenarios, and they would do the stent. Now, is it money? Is it legal? Is it they don't believe the evidence? I don't know. But you can't get past the fact that we are much different, for example, than Canada in terms of interventional cardiology. And they're not dropping like flies north of the border of coronary disease. Our coronary death rates are actually very, very similar, especially if you control for ethnicity, risk factors, and all that stuff. To a man with a hammer, the world looks a nail. It should work, right? I can't convince my mother-in-law that if there's an 80% stenosis and you open it up, that that's not somehow good for you, right? It works in plumbing. Why shouldn't it work? You know, that's not the lesion that gives you the heart attack, and I start drawing plaques. It's not going in. That's not getting me any points. And actually, this is the point. Most of the people who get these things don't pay a lot of money for it. Somebody pays, but they're not taking out a credit card or a checkbook or a wad of cash and saying, here's the $10,000 for this procedure. It's sort of like going to a car dealer and not having to worry about costs. Now, I'm not saying that cost sharing is the answer. You know, I don't know if that's the answer. But part of the problem is the fact that this decision, there's no cost-value decision to this. It's, all right, what the hell? You know, you say it's going to work, I'll do it. So just to put the math out there, compare New York State versus Ontario, so divided by Buffalo, pretty much. And there's just a very different treatment of invasive cardiology. And I'm not going to belabor it. We do a lot of our cardiology is not evidence-based. Most of our PCI is not ACS, is not truly failed medical management. They tried a beta blocker, they tried a calcium channel blocker, they tried a nitro. It's still, they can't play tennis. You know, that's a different group. That's not most of the problem. So then, is it getting better? Well, from the archives from 2 weeks ago. So you want cutting edge? This is cutting edge, right? They did these, I think it was house staff who did this. It was at a VA hospital where they have a standardized formulary. When they order, they get the prices of the drugs they're ordering, because that does have an effect. Maybe not as big as it should, but just like, really? It costs that much? And they have lots of diabetics. So this is not even saying, besides the point that these new fancy diabetic drugs are not necessarily better than the old drugs. That's even a separate discussion, if they should be used at all. But certainly, it's hard to explain this variation, isn't it? This is the same system. And they vary by 2 to 6-fold on how often they use these really expensive medicines. Theoretically, they controlled for clinical factors. Plus, it would be hard to imagine a clinical factor that would explain that variation within a VA male population with diabetics. Why is one group getting cheap drugs and one group getting expensive drugs? It might be which rep visited where, when. It could be who knows what. Some attending, likes this type of drug versus that type of drug. But this type of variation is not going to continue. It can't continue. Somebody's going to have to stop it. Either the docs are going to have to take charge of this and practice autonomy, or the payers are going to say, we're not paying for this. You have to fill out 17 forms if you want to take this expensive drug. And we all rail against that, but this is the reason it happens. This is also from the archives, and this drives me wild. PSA is a very controversial topic. Screening men over 75 is not controversial. The urologists agree. The USFBF-TSPF agrees. Everybody agrees that, there's controversy in it, but over 75, sprint for the finish line. We're not going to screen you for PSA. As Brooklyn would say, you should live so long to die of prostate cancer. There's so many other threats to your life by the time you're that age that if you haven't been diagnosed, good luck to you. So there's no evidence that treating it at that age will do any good. If there's evidence at any age, but certainly not that age. So that should be simple, right? That should be easy. We should be able to pass that test. They still are screening men over 75. This is after the report, after the uproar, after everything. And this is by age. This is not a clinical decision. This is show me your birth certificate. And yet it's not everybody, but it's still a significant percentage. And it didn't change with the evidence. This is probably the worst part, is that when new stuff comes out, you should change your practice. It shouldn't be you practice the way you graduated from residency, which is the way it often is. So, in the last 5 minutes, I'll solve the problem. I don't know. I was gratified to answer promptly. I said, I don't know. So in general, none of the solutions are going to be overly palatable. But you can disguise them, you can twist them, you can frame them in a different way, but in the end, you're going to have to move the money. The docs can't be paid fee for service. Hospitals can't be paid per admission. And you want to reduce things or change things. So bundle payment means you just admitted a patient with pneumonia. Here's $500. It's going to end up like in her lap. Here's $500. The only laugh I got was broad physical comedy. So that's what you guys like. Okay. So here's $500. You take care of the patient. Global payments is Lutheran healthcare system. Mrs. Jones is your patient for the year. If she needs anything, you take care of it. If she doesn't need anything, you keep the money. Now that creates incentives the other way, which is a problem. But in the end, you're not going to control costs if you get more for doing. It's just not going to happen. So then, competitive bidding, we spoke about, in most of the market in America, how do we control prices? By competition and price sensitivity. I took a course in economics, and the only thing I remembered was price sensitivity. Sort of like embryology. I shouldn't say that, it's from my medical school, but embryology was 2 points on one of the tests we took. 2 questions, and I said, I will start with a 98. because I am not going to remember blastula, morula, frugula. I said, you know what? I won't be an embryologist. So we're going to have to do competitive bidding, exchanges, tiered products. This is tricky. You know, this is reward points, right? Dr. Rifkin is a high quality, low cost internist. If you go to him, there's no copay. If you go to somebody else, it costs you $10, $15. So we're going to steer things to him. Now, theoretically, if they're making the decision on the right things, that's fine. Historically, measures have been fraught with problems. Doctors are rightfully scared that they're going to be measured. Are you measuring me? Are you measuring my group? Are you measuring my world? Or are you just measuring my decision making? And that's a tricky area. There's low-hanging fruit, and that's what they'll do first. Is some of these easy things like the forms. Malpractice safe harbor, I think it's an interesting way to go. That if you practice the right type of medicine, you practice by an evidence-based guideline, you do the right things, like and you don't do the PSA for the right reasons, you then can't be sued for it. Because that is just not fair. You don't want to just wipe it out altogether, because malpractice, unfortunately, is one of the few things that sort of keeps doctors focused in terms of, I'd better get this right because, other than their professional ethics. So, but safe harbor is an interesting idea. In general, for you individually, don't be the first to try a new drug, new therapy. Don't be the last. Go with the evidence. Advocate for your patients, even if this sometimes means say no. There's a long example of where no is the right answer. Lidocaine post-MI, PSA screening perhaps, shaving patients pre-op. There's a whole long list of things that were right and then turned out to be wrong. Ask for the evidence. Evidence is not if there's better evidence available. And if there isn't better evidence available, it doesn't mean you don't do anything, but it means you're aware that you're in an evidence-free zone. So I'm not going to be dogmatic about shaving patients until I see that there's some benefit to it. Not everything is provable, but first do no harm. The burden of proof is on the intervention. Right? This is a big thing in medicine. When in doubt, don't just do something, stand there. Don't say, well, I think it's going to work opening up that 80% lesion. Show me it works opening up that 80% lesion. Because the assumption is, leave her alone. And it should come from the docs. Theoretically, if doctors want to be autonomous, the ACC should be the one saying this about the lesions. And they do a little bit, but not all the way. And the AUA should be the one talking about PSA, not the payers. And this is all easy until we get down to that really tough decision of it works a little, but it costs a lot. And the great example of that, and I won't go into great detail, is low-dose CT screening for lung cancer. It looks like it works a little. Is it worth it? There's pros to it, there's cons to it, there's side effects to it, there's a lot of costs to it. Is that money better spent somewhere else? And then an interesting thing is, even if you should do it, it's really for a very specific group. This is the official recommendation. It's not everybody, and it's not in every community. You can't just, you hear it on the radio. That's not the same as when it was done in the center. But that's a common theme, that something gets done in one area, and we spread it out all over. And if it was effective here, it doesn't mean it's going to be effective there. So that's why repeat trials, and that's where observational research is very useful. And then I talked about tort reforms. And really, the upshot's going to be, if we don't do something about this as doctors, if we don't take the lead in doing this sort of thing, other people will. It'll either be the payers or the government. So if we want to be autonomous, we have to practice autonomy. And I think I will leave it with that. And then anybody who shows quotes during their talk is not really trying. Thank you.
So what does Obamacare have in store for us? They have bundled payments coming. There's global payments that we can get doctors? What else is there?
I think the biggest thing is there's carrots and sticks. The carrots are hopefully support to get us onto electronic medical records, and so we could be measuring things the right way. The main moving part to it is moving the money. So instead of it being big, bad WellPoint asking you why you keep capping everybody, it'll be your buddy, Dr. Smith, who now is running your ACO, saying, well, gee, your practice pattern is way out of line with everybody else's. What's going on here? Because you're costing us all our bonus this year. That's the theory behind it. There's lots of little things. Like the theory is that the exchanges will allow buyers to look at health plans, compare apples to apples, and make a decision. I'm going to buy the cheaper health plan. It means I have a lot more shared costs down the road. And if people do that and they have shared costs down the road, the thinking is that that will reduce utilization. Now, it's a fine balance. You don't want the mother with an asthmatic kid to not go to the ER when they have to go to the ER. On the other hand, you don't want them using the ER instead of proper outpatient care. So cost sharing is sort of a mixed message, but it's mostly moving the money. They do talk, they fund way too much of it with waste reduction. And I've shown you that very little of the waste is easy, let's just cut it, everybody's agreed. When you try doing some of this, and you're going to have lots of docs going to Capitol Hill saying you can't cut, I make my living doing head CTs for headaches, you can't cut that type of thing. So we'll see, it's one of those things where there's some structural changes, but most of the actual savings, we'll see.
Like, it used to go me when I was in practice, I'd have patients on Cougar did, and I'd say, patient would come in, who's taking care of your INR? They'd say, my cardiologist. How often you get it in your check? Every week. Every week you're going to a lab? Now, I was a once-a-month fellow, and if they could go 6 months in a row without changing it, I went to every 6 weeks.
Right.
But Medicare would pay that lab every 52 times a year, and I was only, so there was no...
Right, and it's sad if you would hope that the check on that system would not be some Medicare bureaucrat in Washington coming up with a rule that's every 2 weeks. Because then there'd be some patients that you need it more than that. But you're right. That was a variation, and there's got to be something. I mean, one of the things that will change in the future is physician self-referral rules. When the doc who suggests the X-ray makes money on the X-ray, when the doc who suggests, I have a friend who, whenever he goes to the doc, he gets a Chem 4000, including a syphilis, RPR. The guy's like flattered that he's asking for an RPR, but it's such a waste of money. It's such a waste of money, but right now that's below the health payers' radar. They're not worried about who's ordering RPRs, but it's a sign that you want the control to be from us, not from an external rule, if possible.
I cleared a patient yesterday who's going for sigmoid resection. He was good functional status, walked out there, said, right, no problem, no problem, he's clear. And yet you call a cardiologist, some cardiologists in the hospital will send him for a stress test.
Absolutely.
Echocardiogram, Holter monitor.
Right.
Right? So the bundle payments will take care of that.
Well, it would be very interesting. You're right, because all of a sudden, then the concern is the opposite. Then the concern is the person who really needs the stress test, the chintzy doctors won't open up their purse to give them the stress test. But I think that's easier addressed than this, where it's really hard to separate for that cardiologist. Is he risk stratifying the patients, or is he does this for every patient, and it's really hard to separate out his livelihood from his professional decisions.
Other questions? Well, I want to say it's a very exciting time in medicine. There have been, changes in each generation, and this is a big one. I will mention that Dr. Giotto is going to be rolling out the ACT curriculum on cost-effective care. I guess that's going to be starting in a couple of months. So this is a wonderful underpinning for that. And please join me in thanking Dr. Rifkin for a very entertaining and important talk.